we've already said actually quite a lot of what I want to say, but if we just go on to this next bits, and in many ways, you know, this is one of the most difficult jobs in the entire part of neonatology. I personally found counselling parents in a way which was both accurate and at the same time compassionate and gentle. I found that an extraordinarily challenging and perhaps the most difficult part of my job. It was much easier making the clinical decisions and making the clinical management than actually counselling parents. But I think we have to see that this is an essential part of our vocation. This is an essential part of what our job entails. And I've absolutely no doubt that if we do it well, it actually has long-term positive outcomes. And if we do it badly, it has long-term negative outcomes. And I saw in my own clinical career how both of those things, I saw how when the parent had been, when it had been explained in a really positive way, in a helpful way, that really helped the parents in the way in their attitude to their child. But I also saw the negative side, and that is that if parents had had a very negative counselling experience, then it led to long-term negative effects in the way they. And one of the things you need to remember is that parents sometimes have very, very often extremely good recall for exactly the words that are used in some of these conversations. And they may say years later, you know, the doctor said he was never walk, or the doctor said he was like a vegetable. And those words have stayed in their mind and been memorized and rehearsed and thought through, sometimes for years later, even though the neonatologists themselves might have completely forgotten what they actually said. And it may have not meant it in the first place. It was just, it came out in a not very helpful way and all the rest, but nonetheless. So we just have to remember how significant these conversations are, and therefore how careful we have to be in the way that we manage them. So if we know that we're going to, let's imagine that we've got a preterm baby on the unit, and it shows a high-risk scan. It shows a hemorrhagic infarct, a grade 4 hemorrhage, and a poor encephalic cyst, say. So how am I going to discuss this with the parents? And so the first thing to say is to choose the setting carefully. Absolutely the worst place to have this conversation is on the NICU by the incubator and with other people listening. So having a dedicated conversation space or bad news room is really important. And you want to try and make sure that that place is quiet, that it's private, that it's pleasant, that you're not going to be interrupted, that it's a place where you can express emotion privately without feeling embarrassed, and so on. So, and I think just making time thinking about the setting and making sure you have the right kind of setting is really important. And when we were having these kind of conversations, we used to put a special code on the door so that people would assign which other staff would know the meaning of, and that meant don't interrupt. There's a serious conversation going on. Second, wherever possible, you should speak to both parents. I think it's really bad practice to speak to one parent, particularly if you're communicating bad news, because you're then putting a greater burden on that parent to communicate to the other parent. So even if, for instance, they would say, well, I'm sorry, the other person's working or they're not here or so on, I would be quite strong and say, I need to speak to both parents, and you need to find a way to get them both together in the same room. If the mother is single and unsupported, then you need to find somebody else who's going to be there for the discussion. So I would say in that case, the best person is the grandmother or the grandparents, the mother's mother, and if you, or else a very close friend. So you should ask the mother, who else do you want to come and support you? But it's very important by having another person there in the room. Now, both they can provide emotional support for the mother, but also they can hear what is said and act as a kind of objective memory in the conversation. And if necessary, they can act as a kind of advocate for the mother if the mother is so overwhelmed with grief or whatever. And then I think it's good practice to have a third person in the room who is usually a member of the nursing staff, but somebody who is there to support the mother, seen as a supportive, compassionate presence, particularly if there's bad news to communicate. The next thing is the importance of preparing in detail, because I'm afraid there were many examples where I didn't prepare properly. I went into the room, I started the conversation, then I suddenly discovered I was making mistakes. I mean, sometimes I hadn't worked out whether it was a boy or a girl. I used the wrong name. I didn't know the details of the family. I got the history wrong. I hadn't quite remembered the precise details of the scan. All those things normally you can get away with, but in this situation they are disastrous because they destroy the trust. You know, how can I trust you if you don't even know whether my child is a boy or a girl? You know, how can I trust you when you haven't got the details right? So taking the time to prepare, you know, even if it takes 10, 15, 20 minutes to go through the notes and remind yourself about the family history and the previous history and what the scan showed and what the progression of events was and all that, what the pregnancy was like. That, I think that is a really important part of the process. And while you're preparing yourself, you may well want to prepare, what kind of words am I going to use? So I think it's quite helpful to think in advance, how am I going to describe this scan? What words am I going to use? And also, how am I going to describe what the prognosis is? What particular words am I going to use? Because if I've thought through in advance what words I'm going to use, it's more likely that I'm going to be able to speak in a thoughtful and helpful way. If I'm just hoping that something will plop into my head at the moment when I'm there with the parents, I might well say something rather stupid or not particularly thoughtful. So that's why actually thinking in advance about the kind of words I'm going to use, it is helpful. And what we're aiming for when we're choosing words is this combination. We're aiming for, on the one hand, clarity, but on the other hand, sensitivity. And there tends to be a spectrum. You know, you get some people who speak and it's very, very clear, but it's quite brutal. You know, your baby is brain damaged. It's going to affect them for the rest of your life. You know, there's damage to this part of the brain. You know, it's clear, but it's brutal. But on the other extreme, you get people where, you know, well, we're on the one hand and on the other, and, you know, and we're doing the best, and it's all very, very soft, touchy-feely. But in the end, the parents don't understand what you're talking about. It's all too vague. And so we're trying to find words which are both clear, but at the same time, sensitive and compassionate. So starting off, having introduced yourself and explained what the purpose of this discussion is, I think the first important thing is that you express concern and compassion and empathy. You start off by saying, by showing that you understand this is a very difficult time. You know, we understand, I understand you must be very worried and concerned about your baby's been very sick. you know, we've been doing all these various tests, and I understand this is a really difficult time for you, and it's a difficult time for all of us, but I'm here to try to explain what we've found and what the implications are going to be. So something like that, express concern and compassion. And then, as I said before, I think this image of the jigsaw puzzle, I want to put together all the little pieces together. So instead of going straight at and saying, well, your baby had an ultrasound scan and it showed a large hemorrhage, that's not, I think, the way to do it, because immediately you have given the impression that all that matters is the scan. So my experience is the best way of managing these conversations is actually to go through the history together, chronologically. So what I would say is something like, what I'd like to do is just discuss with you all the things that happened to your baby. So the first thing that happened was the pregnancy was going on quite well and everything seemed okay, didn't it? Until we got to 22 weeks. And then at 22 weeks, then you had this difficulty, didn't you? And then you started going into labor. Is that right? And then you had to come into the hospital. Yeah, that's right. And then what happened? And then you had these, and then the baby was delivered. Okay, and so then we had a team present at the delivery, and the baby came out, and the baby was in quite good condition to begin with, but then developed these respiratory problems, and you know the baby then had to go on the breathing machine. And to begin with, the baby seemed very stable, but then we had this difficult period on the second day of life, and the blood pressure was very low. And you remember when we had to do blood transfusions, you sort of go through the history chronologically. This happened, then this happened, and you get them to be part of this. You know, you check with them, is that right? And that must have been quite worrying for you, and so on. And then we did an ultrasound scan, and the ultrasound scan showed this. And then, so then you're putting the ultrasound scan in the context of the overall clinical picture and the sequence of events. And the ultrasound scan showed that there was bleeding. Unfortunately, it shows that there's been bleeding in the center of the brain, and it starts in this region of the brain. And it may be helpful to have the image there and be able to show them where the germinal matrix starts and how the bleeding has gone into the scan, and just explaining about the scan. It isn't essential to have the pictures unless people ask to see them, but explaining in words, there's bleeding. I often use the phrase bruising because it doesn't sound quite so bad. Bruising in the center of the brain. And this has now spread and affected some of the connections in the brain, the part of the brain which is to do with connections. And unfortunately, we think it's very likely that that's going to have some kind of long-term consequences. And then I would discuss what those possible long-term consequences were, but I would avoid giving precise numerical statistics. I mean, telling someone their child has a 25% chance of having problems or a 60% chance of having problems, I mean, frankly, it doesn't, what does 60% mean? You know, my child is one person, and they either have problems or they don't, and knowing that it's 60% or 30% or doesn't really help. So I would tend to use figures like the majority of babies with this will have some kind of problem, or there's a small chance of problems, such as those kind of vague ones. But unless people were being really pushing me very hard, I wouldn't give precise numbers. And as I've said before, don't destroy hope, even with a high-risk lesion. So I would say, for instance, in the grade 4 hemorrhage, I would say something like, unfortunately, what our follow-up study shows is that the majority of babies who have this kind of picture on the scan will have some kind of problems or difficulty with movement later on in life. And I would then discuss the sort of things that would mean. But what I would point out is, first, there's a huge range. For instance, if it's a unilateral HPI, the most likely outcome is a contralateral hemiplegia, where the arm is more severely affected than the leg. And so I would, if necessary, and if they asked me to, talk about what it would be like for a child with a hemiplegia. And interestingly, actually, having seen many in the follow-up clinic, children with a hemiplegia often do remarkably well, because if you've got one good arm and one good hand, that means you can write, you can operate a computer, you can operate machinery. And if you've got one good leg, that means you can be mobile. And in most cases, even if you've got a very abnormal gait, you can get around reasonably well. So understanding the difference between a sort of unilateral HPI compared with, say, spastic diplegia, which you'd get following PVL, you know, and being able to talk to people about what the implications might be for a child. But I would also say I might be wrong. We do know that some babies do incredibly well, even though the scan shows this. And therefore, I have to be honest with you. And to be honest, that's what we're hoping. We're hoping that your baby's going to do really well. But I have to warn you that there's quite a chance that this child is going to have problems. So what are we going to do? Well, what you mustn't leave people with bad news and then say, well, that's all we can do. I think what's really important is that you discuss the next steps. Before you end the conversation, you discuss what's going to happen next and what are we going to do to help you. And so that what it might be, well, the first thing is that I'm going to ask the nurses to stay with you here. And if you've got any comments or questions, you can give them to her and she can pass them on to me. The next thing is I want you to write down any questions or things you don't understand. And I'm going to come back and see you in 48 hours time. And we're going to have another conversation. We'll discuss then and go through things again. I'm going to ask the physio to come and talk to you about what exercises you can do with your child. We're going to refer her to the multidisciplinary team. And so you're mapping out what the steps are and the positive things that you could do. So I would emphasize, you know, she's going to teach you, parents, how to do physio so that you can do the best things for your child and you can make a real difference. And then it's really important, as you walk out of the room, the temptation is to mop your brow and say, thank goodness that's finished, and I'll just go off and have a cup of tea. But actually, you mustn't do that. What you've now got to do is you've got to write a detailed account in the notes, because it's really important that the rest of the neonatal unit staff know what you've said and the words you've used and the language so that they can reinforce it. So you need to write down however you do this in some detail how the conversation went, what words you've used, and what the plan is looking forward. So here are some useful phrases that I've used and other people have used. Lots of parents think that we know exactly what's going to happen because we're clever doctors and we've got all this wonderful machinery and scans, but we're not telling them because we don't want to hurt them. And so you've actually got to explain, look, honestly, I can't tell you exactly what's going to happen. The best doctors in the world can't tell you what's going to happen. Nobody has the second sight. I would explain about how the brain adapts and grows after the child goes home, makes new connections. The most important thing is not what the scan shows, but how your baby develops in the future. So the fact that the scan is worrying does not mean that the baby's going to have a catastrophic future. What's most important is practically how the baby develops. In the end, we all want to do what is best for your baby. That's a useful phrase if we're talking about withdrawing intensive support as well. We're all trying to do the best. It's not that we're against your baby. It's not that we're trying to harm you, but we want to do the right thing. And your baby may prove us all wrong, and I really hope that she does. You know, in other words, you know, even though we're worried that the child's going to have adverse outcome, we may be wrong, and you're remaining giving people that hope. We won't focus on the scan, we'll focus on how your baby is doing and making sure that we give him the best possible care. And a famous phrase, sometimes we need to hope for the best, but prepare for the worst. You are the most important person for how your baby develops in the future. So you mustn't disempower the mother and disempower the parents. It's easy for them to think, you know, well, I'm not a neonatologist and I'm not a physiotherapist and I'm not a behavioral psychologist, so there's nothing I can do for my child. And you need to help them to see, on the contrary, as those statistics I said about maternal education show, you are the mother is the most important person for how the baby develops in the future. There are lots of other people who can provide input, but no one else can be a mother. And we're here to support and care for you and your baby. Whatever happens, we'll be here for you. And this is what not to say. I know how you feel, because the right answer to that, if you say that, is, you don't know how I feel, doctor, and I hope to God you never do. So don't say, I know how you feel. Don't say, if we had known how bad the injury was going to be, we would never have resuscitated her. I've heard doctors say that to parents. Don't say, we all feel really guilty about how things have turned out. I mean, you may feel guilty, but don't do your psychotherapy on the patients, on the parents. If you feel really guilty, then you need to talk to your colleagues, or you need to go and talk to a counsellor. But don't put your guilt on the parents. I've seen that happen many times, where doctors, because they felt guilty, they felt they had to sort of pass on their guilt onto the mother. But actually, it doesn't help. It doesn't help the mother to know that the doctor feels guilty. And don't make these confident negative predictions. I need to tell you that he'll never walk, he'll never talk, he'll never speak, he'll never have a normal life. You don't know that. The statistics can't tell you that. And you have no right to make those, to say those negative things. And just to finish, if you haven't seen this paper and read it, can I recommend it to you? It was in Acta Pediatrica 2014. And it was written by a group of parents of extremely prem babies. And it gives you the parent's perspective of having an extreme prem baby in a NICU. And it's very, very helpful. So this is some of the things they said. Our unborn children have a story and are part of our hopes and dreams. Do not use gestational age to categorize our child. Oh, you're the mother of the 23-weeker. My baby is not a 23-weeker. My baby has a name. Each baby is different. Have a personalized approach. You can tell us what generally happens to children about to be born at the same stage of gestation as our child, but please also describe to us the particularities of our child. That will influence his or her outcome. Each family is different. We disagree that every family needs to receive extensive information about everything negative that may happen. Some parents want statistics, others want the general pictures. Some parents want to make important decisions on their own, while others want recommendations. Please listen to us individually. We need to trust you. Do not tell us that babies at 22 or 23 weeks do not survive. Do not tell us that most preterm infants are disabled. We rely on you to know your data. Reflect on the differences between numbers and medical values. Do not tell parents that their child will have a negative impact on their family. You don't have the data to support these claims. Many clinicians decide that giving babies a chance is not worth it for a 10 to 20% survival rate. Our discussion should be about values and not about percentages. Do not take away the hope we have. There is always hope that we will deliver tomorrow. There is hope that we will be able to spend some time with our child. There is hope that we can survive the death of our child with positive memories. Do not abandon us. Instead, tell us that you will be there whatever happens. Okay, happy to respond to any thoughts or comments. You're muted, Ella.
Prof, I was going to ask a question. One of the things that sometimes we find ourselves in a situation where parents put the questions back to us and ask us about what we would do if we were in that situation. And I'm just curious, I mean, how do you approach that? Because clearly, you know, we've never been in that situation, and it would be so judgmental for us to even say anything. I'm just curious to know your
yeah, well, it's interesting, isn't it? I mean, I know that the received wisdom is that you should never answer that question, but actually I think that's wrong. I have answered that question sometimes. I think, again, you just have to take every case on its own merits, and you need to work out what is the relationship, you know, what would be helpful. But there certainly are some situations. I mean, I think, you know, what is the physician there for? Well, partly they're there for technical expertise, and, you know, for our expertise about prognosis and therapies and outcomes and risks and all that. But, you know, partly the physician is there to be a wise friend. And if you were in some completely different situation, I don't know, imagine you're about to buy a house or something like that, and there's this very complicated decision and you really don't know what to do, but you've got this guy who knows a great deal about houses and who is a good friend. I think it's perfectly reasonable to say, if you were in my situation, what would you do? And to give them an honest answer. So if that's true about any other area of life, why is it not true about medicine? So I think, of course, I would preface it by, you know, to be honest, I've never been there. I've never had a baby at 24 weeks. I can't put myself totally in that position. But from everything I know, if I was in this situation, to be honest, this is what I would want. You know, I'd want to have the best. I'd want to have maximal support because I know that babies can recover from this. Or, to be honest, I would want to stop treatment and give my baby comfort care. Now, somebody else might come to some other decision, but you've asked me and I've given you an honest answer. Now, I wouldn't always do that. In some situations, I would just say, I don't think that's appropriate. But there are situations where I feel being a wise friend means giving my honest personal opinion.
That's really helpful. Prof, I was also going to say that in some situations, sometimes we disagree with parents, and it might be about us talking about scans. There may be an element of denial that comes in. And I mean, really, it's never one conversation. Obviously, if we're worried about a particular outcome and we encounter that, what would your approach be in that situation? How important it is? I mean, giving them hope is so important, but also the message that you might want to convey. And by no means is it certain. And that's another area that I really struggle with.
Yeah. Well, I think, again, it's all about trust, isn't it? It's building a relationship of trust. And I do understand that this is becoming more and more difficult. And actually, you know, if I look across my career, I started in working in neonates in the early 80s, 1980s. And just the difference between the 1980s and the 2020s, there has been such a loss of trust in authority figures, and a consultant is an authority figure. And I think it is hard to get people to trust you and to show them that you are trustworthy. And I think it's also been made much worse by the constant turnover of the staff. You see, so in my day, in the bad old days, we would have one of the attending neonatologists who was basically regarded as the attending neonatologist for 2 months at a time. And everybody knew who the attending person was, and every parent knew that that was the person who ultimately they had to talk to and who carried the can. And it was absolute hell going on for 2 months. But in terms of continuity of care, it meant that you were the ones who had the conversations. And the agreement with the other neonatologists was that although they would do the on-calls, they wouldn't take major management decisions wherever possible without the attending consultant. I think, unfortunately, these days, what you often get is people changing every 24 hours. And so the parents are exposed to a constant stream of a different doctor, a different doctor, a different doctor, a different doctor, and every doctor says a different thing. And how on earth can I trust you when you all say different things? And of course, from a parent's point of view, you can see that, can't you? How difficult it would be if a constant succession of strangers comes along. So I don't really know what the answer to that is. I do think my suggestion, and some places have tried to implement this, is that every long-term baby ought to have one nominated consultant who does all the communication. And unless that's absolutely essential, the serious communication is left to that named consultant for each baby, because I think there's that way of, so I think you've got to build trust. And then I think you've got to try to build up the relationship, and by showing that you're being honest, by showing that you're listening, by showing that you're prepared to have repeated conversations, and that you're not going to try and pressurize or abuse, but that you're just trying to be straight, and by being honest about the things you don't know and the things you can't be certain about. And my experience was that in most cases it was possible with time to establish a relationship of trust, but it's not 100%. And sometimes you just find that for whatever reason we cannot establish a relationship of trust. And I think in that case, then you should say, well, we're clearly not doing very well. Can I suggest another doctor who's going to manage your baby and take these decisions, and you can discuss them with them. So I do think you have to be prepared for that. And I do think that asking for a second opinion, asking for someone independent to come and explaining, that obviously you're finding it difficult to accept this, and therefore you ask for somebody quite independent to come and talk, and that, I think that can help. But yeah, I don't know if that's helpful. It just sort of...
That is really helpful. I think, especially in our times, as you've said, with the media as well, it's a real challenge. Parents are very well informed, and I would say potential of disinformation is also exists. So completely accept that. One of my other questions was around anger, and obviously with any information that we give to parents, there's always an element of our nonverbal skills that come into it. And clearly, sometimes information can be conveyed in a way that makes parents angry. And I'm just curious, how have you approached that?
I do think that when parents become very angry, it is one of the hardest things to take, particularly when you feel that you have put an extraordinary amount of time and energy and care to do the baby, and then you just get hostility and anger, and I think that's very hard to take as a professional. But I'm afraid, I think you just have to accept that this is part of the it goes along with the territory, and that most of the time people are responding with anger. Actually, it's out of their own emotions and fear and concern, much more than that. It's actually not really directed at you, even though they may express it as being angry at you. You just have to try to distance yourself from it and say, these people are just very distressed and very frightened, and they're just taking it out. It's like they're lashing out, and I'm afraid you just have to take it and show that you don't take it personally. And I think the phrase, "I understand this is very difficult for you," I think you just have to keep saying this. I understand this is difficult, and maybe let's have a timeout and let's allow tempers to cool down and so on. But I think this is where it's important for us as neonatologists and as physicians to have our own support network. I think every one of us needs to have others where we can just go and talk about how difficult it's been and about our own emotional responses. But as I say, we shouldn't take it out on the parents. We shouldn't try and do our own psychotherapy on the parents. We have to, in a sense, to absorb this from the parents, and then we go and do it elsewhere. But we do need to make sure that there is that kind of supportive network where other people who understand, where we can put out our frustrations and the negative feelings and so on.
So I'm just going to open the floor to the audience. Sorry, I interrupted you, Prof.
No, just the other thing I think is that I think we should be looking for the signs of burnout. You know, neonatology is a very intense specialty, and all of us are capable of becoming burnt out. And we need to recognize what are the signs of burnout. And I think one of the, for me, the most important signs of burnout is compassion fatigue. It's when actually, you know, I know this is all very sad and all the rest, but frankly, I don't give a damn. Once I start feeling like that, this kind of blunting of my feelings and my empathy, that's a real warning sign that I'm getting burnt out. And actually the only cure for burnout is you have to have a break. You have to get out of the NICU and spend a time, you know, for recuperation. And I think sometimes we need to have systems where we should rotate people. You know, you spend a time working in NICU, but then you need to be rotated out and to have a period of recovery in some other area, so to avoid this just continual burnout.
So I'd just like to invite any questions from the audience. So I've got a question from one of my colleagues, which has come through over YouTube, and his question is about the situation of using a room. And one of his comments is that sometimes the Breaking Bad newsroom becomes an area of worry for the parents because we're taking them back to that room. And, you know, it's something that I've encountered as well. We have a green room in our hospital where I think our biggest challenge is sometimes the first conversation is obviously not good news. And then when we say we're going back to the green room for further conversations, it becomes tricky. And I mean, have you been in that situation? How have you approached it?
Yeah, that's really interesting, isn't it? And you can see why that happens. You know, people do become traumatized by a particular setting. And maybe we just need to be flexible and think, well, okay, if this is a very painful setting, can we find some other place? Maybe an office, maybe, you know, somewhere else, somewhere in outpatients. You know, I think we can be flexible and recognize that certain settings, certain reminders may be very triggering for people and very unpleasant. So again, it's trying to see it through the parent's eyes. You know, the whole art is empathy, trying to see it through their eyes instead of just through our own experience. And I think so often we fail because all we can do is just see it through our own eyes, and we find it impossible to imagine what it's like for parents. And there's no doubt, I think, you know, it must be one of the worst experiences possible to be, you know, to us, a NICU is a completely normal, routine environment, but for them, a NICU is a bizarre, terrifying, you know, place where these little babies teeter between life and death, and where terrible things are happening, and my child might be permanently damaged, and events happen from moment to moment. So you can see how profoundly traumatizing it can be for parents, and I think we just need to support them. But interestingly, this comes back to the not destroying hope. You see, one of the things I realized over the years, you get some parents who are so filled with anxiety, and they keep asking you, you know, but what about, you know, could you explain to me how the mechanism of PVL, could you explain to me where on the scan the damage is? And the more time we spend explaining about mechanisms of brain damage and white matter and long-term outcome and so on, all we're doing is we're just feeding this anxiety. And I think we're not necessarily helping a great deal. Whereas the other parents, you know, I meet other parents who say, well, I hear what you say, doctor, but I think she's a little fighter, and I think she's going to be all right. And what I find is that emotionally, you might think that's denial, but actually those people often do emotionally so much better And they may well be right. It might turn out that she was a little fighter and that she did a lot better, despite the fact there was PVL there. So it's trying to support the parents emotionally through this experience and recognize that a certain amount of denial is absolutely essential. I mean, as a parent, for those of you who are parents, you know that we all have denial about our kids. You know, if we were ruthlessly honest about quite how awful all our kids were and all their problems and so on, you know, what kind of parents would we be? But, you know, we look at our children and we say, well, they have all these problems, but you know what? I love them. I love her, you know, and she's wonderful. And that's part of being a parent. So why are we destroying that proper kind of denial in our parents?
That is so helpful, Prof. I can't thank you enough for having taken this session for us. I mean, each time I've been able to hear you speak, there is everything, certain pearls of wisdom that I take back that, you know, to this date have actually helped me in situations and been very formative in my development as a consultant neonatologist. I would like to thank you on behalf of, you know, my colleagues, the network, and all the participants who are here today. And I mean, just to give you a little bit of a flavor, we had a total of 69 today. And this is from virtually every continent, including Africa. So I can't thank you enough for being with us. And, you know, I'm hoping that, you know, at some point we might be able to come back to you for more.
Yeah. No, absolutely. Yes, please do. And I'll share my PowerPoints. So if please, if you'd like to just circulate the PowerPoint. I don't think it's got any, I'm just thinking, has it got any images of babies? I don't think it has. I think therefore there's nothing therefore that I would be worried about from a confidentiality point of view. So please feel free to use it. And in case you're interested, I have a website, johnwyatt.com. It has some neonatal content on there, as well as quite a lot of other ethical and philosophical stuff. Great, thank you so much.
We're grateful.
It's very good to, and greetings to all you across the world. It's amazing, this technology, and it's wonderful to be part of it.
Thank you.
Thanks then, I'll leave. Goodbye.
Thank you very much, Dr. Wyatt. Thanks.